All right, everyone, and welcome back. This is the part two of the PMHNP crash course review. Here, it's a super important. It's what you need to know. In fact, I'm gonna highlight this. Every example you need to know. Every line here you need to know. If it wasn't important, I would not put into this must know review. Okay. In fact, I did not even provide you a PDF like I do for the 30 days PMHNP Walk to Success. Well, why not? It's simple. I want you to stop the video and write it down. Every single word that's in here, you need to write down. Why? Because everything is important. It's not just the highlighted portions, it's not just the bold portions, every single thing. So let's go. Let's do this kind of fast, in a hurry, but make sure you understand the content as you walk into the test center. You are no longer afraid of the test. You will ace the board certification. My name is Dr. Lopez. Let's do this, guys. So here we have our roadmap to success. Every training, I provide a roadmap to success, and this will not be different. We have here the inducers and inhibitors, followed by medications that can cause mania and depression, anxieties, anorexia, bipolar, personality disorder, conversion disorder, malingering versus factitious disease. You need to know this, guys. Adjustment disorder, oppositional defiant disorders, or ODD, um, conduct disorder, Tourette's, super high yield, PTSD versus acute stress disorders, ADHD. Oh my, you will see questions though. ADHD, I can guarantee you. Signs of stimulant abuse, right? Practicing safely. That's what the board wants you to know. And OCD. So I hope hopefully you have watched our strategy video, and this is our part two. Let's go. Inducers versus inhibitors. Super high yield. You will see questions about inducers and inhibitors. We covered this in detail in our previous module. Well, let's start with CYP1A2. CYP1A2 primarily metabolize clonopin and alonzopine. Write it down. Alonzopine as well. So inducers, you have the D for decrease. Inducers, you have the D for the decrease the serum level of other drugs. Example, practical example you need to know. When the patient is taking olanzapine, right, and starts smoking, if it's a inducer, so it is necessary an increase of the dose because you have the CYP1A2 and you have the inducer, right? So it decreases the drug amount. Okay, you need to know. So it's necessary. It decreases the drug amount. So your primary action is to increase the dose because you have less of it, either clozapine or olanzapine. Okay. Now, another example you need to know: if the patient stopped to smoke, then you need to decrease the dose due to possible toxicity levels. So stop you need to decrease the dose because the patient stopped smoking. Okay. Now, inhibitors, you have the I for inhibitors, which means the increase. If you had the D for inducers that decrease the amount of level of the serum levels, the I for inhibitors increase the serum drug levels, potentially require adjustment to prevent toxicity. Okay, example: a patient on medication X and a inhibitor inhibitory medication may need a dose reduction of medication X to avoid toxicity, right? So if you have a medication X and you have another medication that's an inhibitor, right? Because inhibitor increase the medication X, you need a reduction of the medication to avoid toxicity. You need to know this. If a patient takes both inducer and the inhibitor, inducer here is tagritol, and the inhibitor here such as clarithromycin or erythromycin. That's an inhibitor, right? The inhibitor wins could increase the concentration of the inducer. So if you taking a inducer and the inhibitor usually wins, thus necessitating a reduction of the targetol or coordination with the primary care provider. So options here, your priority is to reduce the target toll or you coordinate, remember collaboration, you coordinate with your primary care provider. Please write it down. Every single thing here needs to be written down. Medication that can cause mania and depression, mania and depression. So, mania, let's start with steroids. Anti-abuse can cause mania. Isoniazid can cause mania, and antidepressants, all of them can cause mania with those with the predisposability for bipolar disorder. So, all four medications there you need to know. Medication that can cause depression, we have steroids, beta blocker, interferon, isonitrate, which is a cutaneous super high yield that you need to know that can cause birth defect. Some antiviral medications, any medications that uh, antineoplastic medication, cancer drugs, benzodiazepine, no surprise, progesterone can also cause depression. Now, steroids again can cause uh, psychosis and also can cause depression. So steroids can cause both, right? It can cause psychosis, it can cause depression, and they can cause many. Okay, steroids can cause both. So pay attention what drug you have, and these steroids oftentimes will not come in a easy saying, "Oh, this is a steroid." This is your part that you need to know this is a steroid. Example, Flonase or prednisone, right? It's not saying it's a steroid. It's your job to know this is a steroid. So, for example, Flonase or prednisone is used in patients being treated for mood disorders um, with a patient. So if a patient is being treated for mood disorders with lithium, Depakote, or Targetol, assess which medication cause the unwanted side effect. So your action is to increase the psychotropic medication because you have Flonase in addition to any of those mood stabilizers that we mentioned. So if you have Flonase plus lithium Depakote or Targetol, assess which medication caused the unwanted side effect. And then your action here is to increase the psychotropic drug. Okay. So you can, if the options is to collaborate, then you collaborate with the primary provider to see if Flonase can be terminated, or you increase the psychotropic drug. Okay, why? Because the Flonase is a steroid, right? As we mentioned here, Flonase is a steroid, and if it's causing mania, we need to increase. If it's causing depression, if it's mania, we need to decrease, right? The If it's causing mania, and you need to increase one of those the drugs that we mentioned, such as Targetol, Depakote, or Targetol. if it's causing mania due to the flonase. Now, what if it's causing depression? And then you have the same medication, a steroid, such as flonase or prednisone, then your action is to increase the SSRIs. Or your action, your priority action is to collaborate depending how the question is being asked. Okay? Now let's talk about Lexapro and interferon. So let's go back here and see again. Interferon can cause depression, right? So here we have an SSRI and the interferon. So if a patient's return late stating that the dose is ineffective, then increase the dose of chin 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 Lexapro. So the same concept by knowing which drug causes mania and depression, you need to adjust your psychotropic medication to overcome the other medication. So, also, if the option is to collaborate with a primary care provider, that's an option. That's a good option as well. So, another example, steroid and Abilify. You may need to increase the dose of Abilify to adjust due to the steroids, right? Because steroids can cause mania. And then if you have a patient that's having psychosis or mania, you may need to increase the Abilify. As we mentioned, steroids can cause psychosis. Takeaway: adjust the psychotropic medication due to their drug interactions with any of the above. Okay, super high yield. So this is more than just memorize it. Your understanding is super important. So you need to adjust your psychotropic drug. Okay. All right. Anorexia and pain. We'll cover more of anorexia in the upcoming slides. But anorexia and pain. If the patient is feeling blurry, bloating, fullness due to a delayed of gastric emptying, for example, medication that can cause delay of gastric emptying, Ritidine, phentoin, and omeprazole, all of the three medications can cause a delayed in emptying, right? So your action is to decrease the amount of food intake as the patient may be having a delayed in gastric emptying. Anorexia, I just want to highlight this. If the BMI is less than 15, you must admit the patient. Well, what if the parents don't want to admission the patient? It's refusing. Then your action is to call the CPS if the mother or father or parents or whoever is the guardian is refusing admission. It's saying, well, everything is fine. Well, it's not. Someone with the anorexia and the BMI of less than 15 or 15, it's serious because it messes with the electrolyte. Okay. So again, anorexia is extreme restriction of food intake, intense fear of gaining weight, body weight significant below what's considered healthy, and the distorted body image. Individuals may see themselves as overweight despite being very underweight, right? Mnemonics for anorexia symptoms: fear. So is the F for food restriction, the E for extreme fear of weight gain, A for altered body image, and the R for the rapid weight loss. Okay, so keep on taking it away. All that it's mentioned, including the three medications there for gastric emptying that can cause gastric emptying, your action may be to either stop those medications if it's causing a unwanted side effect, or maybe not necessarily due to anorexia. We don't want to decrease the food intake, but your action may be to stop this medication. If it's a normal person that's having gastric emptying and pain, right? We could say, hey, maybe having a little bit less food, not for anorexia specifically, if they're having decreasing gastric empty, it could be to one of the three medications. Again, BMI less than 15, you must admit. Parents refuse, you must call CPS because the child or teenager is at risk. Okay? We'll cover a little bit more of anorexia in the upcoming slides, but bulimia is another eating disorder with a normal BMI, while anorexia no longer is a normal BMI. Bulimia, periods of eating large amounts of food followed by attempts to prevent weight gain. How so? Well, self induced vomiting, misuse of laxative, or fasting, or excessive exercise. Self esteem is overly influenced by the body shape and weight. The weight of individuals may range from below normal to above normal. So they're very different than anorexia. The BMI is actually normal. Mnemonics for bulimia: binge. So binging episode, inappropriate compensatory behaviors to avoid weight gain, normal weight or overweight typically, guilt after binging. I see this all the time. They feel guilt after vomiting or looking at their knuckles, right? So if you look at their knuckles, it might be have the marks of the teeth because of so much vomiting or produce vomiting there, right? So excessive concern with body shape and weight. All right. So bipolar disorder, let's talk about bipolar disorder. Your first action when you hear bipolar disorder, symptoms of bipolar disorder, is to do a family history across generation, okay? Because it is one of the greatest risk factor. So if you're thinking of bipolar, your action is to do a family history. Bipolar disorder, do not use age as a discrimination. For example, for first bipolar break, do use age as a discrimination. My apologies. So you do use age as a discrimination. I'll correct this slide. You do use age as a discrimination. Why? Let's do an example. For the first bipolar break in a patient that's 45 years old, it may be due to a medical condition rather than a bipolar itself, age 45 and older, right? Mostly due to a medical condition. The same thing goes for schizophrenia. Schizophrenia, males age of 18 to 25, females age 25 to 35, and they're 45 years old having a first psychotic break, most likely is not schizophrenia. So the same thing here for bipolar. If you have someone of age 45 years old and having the first episode of bipolar, watch out. This is due to a medical condition and most likely not due to a psychological condition or psychiatric condition, such as bipolar, right? So, how to know the symptoms of bipolar? Use Dig Fast. I think we've seen and know what Dig Fast stands for. Many questions in the test may not give you all the information for the concrete diagnosis. Remember, you are working with the most likely diagnosis. A patient scenario will not have all the symptoms required and the time frame required for full diagnosis. Rather, the most likely diagnosis giving the presented characteristics in the questions STEAM. All right, just a little bit more because we can never have enough before the test. Dig fast, distractibility, indiscretion, grandioses, flight of ideas, activities is increased, sleep deficit. So the sleep is not that someone is having insomnia, they can't sleep, but they don't need to sleep. They feel so good, so activated that they can just go on for weeks. Well, bipolar 1 is more than 7 days. Hypo Bipolar 2 It's more than 4 days, but less than four, and has an episode of depression as well. Okay, and another symptoms often seen is pressured speech or talking fast. Okay, personality disorder. First thing to know about personality disorder is the age. Age is a discriminator here. Again, age is discriminated. You can only have a personality disorder if the age is 18 or older, right? So if the question's asking about a personality disorder and the patient is 16, you can go ahead and cross that answer. That is the incorrect answer. Personality disorder must be 18 or older. Borderline personality disorder, the biggest risk is self harming behavior. So we want to do therapy to reduce the risk of recurrent suicidal behavior. And that's due to DBT. We want to know who created DBT. It was Marsha Linehan. DBT number one goal is to decrease suicidality in borderline patients. Okay? Every single line on this review is important. It is helpful to ask for a journal diary keeping in order to diagnose someone with bipolar disorder. It is super helpful to collect a diary and keeping a journal as a part of the diagnosis process for borderline personality disorder. Medication for borderline personality disorder. It depends. Well, are they angry? Self harm behavior? Give lithium. Are they depressed? Emotional liability? Interpersonal problems? Rejection sensitivity? And hostility? Or all in some of the combinations of the mentioned? You give Depakote. So, harming self, anger, you give lithium. Anything else, you give Depakote. Antisocial personality disorder is the most likely to commit a crime. Antisocial personality disorder, these are 75% of those in prisons. They have a tendency to have homicidal behavior. As you notice, we're not talking about a whole lot of the personality disorders that we covered throughout the other modules. Here we are going the nitty gritty, most important facts that you need to know for your board. So every line is important, every example is important. Conversion disorders, symptoms begin after a stressful event. Something happened and the symptoms began. Patients usually clear by neurology first. Scenarios. Patient has been clear. Scenarios. The mother died. Patient now is blind. Patient went to the hospital and it was clear by neurology um, team. Now, option A, is this malingering? Option B, is it factitious disorder? Option C, is it conversion disorder? Right? So this is a conversion disorder. Or option D, adjustment disorder. Well, we have a symptoms cleared by neurology, followed by a neurological symptoms of blindness, mutism, paralysis, or paresthesias, right? Glove and stocking syndrome, and other nerve systems like neurologic symptoms or even motor, like I can't walk, right? So that is conversion disorder. Intervention, what medication you gonna give? No, no, no. Therapy is the focus. Therapy is the intervention, the treatment of choice. What are you gonna do? Therapy. Okay. Several therapies are available. So now, since we talked about conversion disorders, and it's at times it can be very confusing the difference between malingering versus conversion disorder versus factitious disease. So it's worth covering. So malingering is characterized by the intentional production of false or grossly exaggerated physical psychological symptoms. Key word here: motivated by external incentive. In order to be malingering, someone has to be gaining something. Okay? It could be do, hey, I don't want to be in a military duty, avoiding work, obtaining financial compensation, evading criminal persecution, or obtaining drugs, whatever the reward is. In order to be malingering, you need a benefit. If the question does not give you a benefit, it's not malingering. On the other hand, factitious disorders, okay, uh, involves a pattern of lying about having physical or psychological symptoms or intentionally producing one of those symptoms without obvious external reward. Again, external reward is not obvious. But why do they do it? They are motivating behind the motivation behind fictitious disorder is a psychological need to take on the sick role, to receive attention, sympathy. Unlike malingering, the symptoms are intangible. It's not money. They wanted to be cared for. And then the inner psychological need drives the behavior. So, factitious disorder imposed on another. Factitious disorder imposed on another. Example, a patient may harm the child physically or psychologically. Your action is to report to CPS. Example, the mother brings the child to the hospital, has been cleared several times, and the child continues to come back and on and on and on, right? Until there might be some examples that the mother is actually producing the symptoms, making the child eating feces, drinking urine, whatever might be the case, right? Your option is your action, your primary action is to report if you suspect factitious disorder. Okay, adjustment disorders, right? So a stressing precedes the symptom. That sounds like conversion disorder, doesn't it? A stress precedes the symptoms. Then the symptoms appears, but the symptoms is different here. Is depression, is anxiety, or others, but you will not see blindness. You will not see paralysis. Okay. Then the diagnosis is most likely a adjustment disorder, MDD. You are not able to identify the cause of the depression. And this is how you distinguish MDD versus adjustment disorder. With adjustment disorder, something happened. They moved, a military move. They went from California to Korea, or a pet died, and now they feel sad, they feel depressed, or, for example, well, let's go on here. Adjustment disorder can be with symptoms of depression, anxiety, or disturbance of conduct, right? So this is not a conduct disorder, but a adjustment disorder or adjustment disorder with both emotional and conduct symptoms, right? So a child presents with the disorder with a mix of disturbance of emotion and conduct. So there are several adjustment disorders. The specifiers, it depends on the scenario, but it all falls within the same realm of question. For example, one had HPV, right? And now, because after being diagnosed with HPV, now she feels or he feels sad, anxious. So the stressor, HPV, the symptoms, depression, it fits the adjustment disorder criteria. Okay, so it's not major depressive disorder Why? Because you are, but because you are able to identify the cause, while MDD you are not. Mostly, you are not able to identify the cause. Okay, oppositional defiant disorder, better known as ODD. Okay, those kids here, they lose temper. They easily annoyed, even though they are annoying others. They are angry and resentful. They blame others. What are we gonna do? What are we gonna do? We are going to give them family therapy with management skills. So the family needs to be involved to taper those symptoms. Teaching parents about positive reinforcement, boundary settings, we need to address this to prevent it from leading to conduct disorder. So, oppositional defiant disorder, oppositional defiant disorder, right? Um, if you don't address, will or can lead to a conduct disorder. Okay. So, all right. Conduct disorder, that's where we don't want to go to. It's more intense. Here, oftentimes, it will come with uh, harmful to cats, animals, dogs, and so forth, destructions of property, violation of the rights of others, aggression towards animal, no remorse, no remorse. These are very key. It must be less than 18 years old. If those uh, traits proceed after 18 years old, where they're going to be, they are going to be categorized as antisocial personality disorder, right? So, tip here, if you read the question and it seems like a very bad behavior problem child, it is conduct disorder. It must be super intense without remorse, right? The question may or may not give you remorse as one of the characteristics, but the symptoms are intense. What are we going to do? Well, medication that targets mood and aggressions. We can do SSRIs. We can do alpha agonists like clonidine or guanfacine. And treatment again, we can do family therapy. Is helpful. So we can do family therapy for oppositional defiant disorder. Okay. And we can do family therapy for conduct disorder, along with guanfacine, clonidine, SSRIs, and such. Okay, but the mainstay for both of them really is family therapy. Tourette's. When you hear Tourette's, you gotta look for two modems and one vocal tick. Okay, stimulants can cause Tourette's. Your action when you hear questions about stimulant cause Tourette's, your action is only one. It's to stop the medication. It's not to change the medication. It's not to decrease the dose. It's not to increase the dose. You stop the medication. Tourette must have at least two modem and one vocal. Modem symptoms can be normal and are likely to disappear in them independently. Now, if they have lasted more than a year, then you have modem and the vocal. This is a Tourette. So what I'm trying to say here, guys, is maybe now well explained on a slide, but let me explain this to you. If the child has just a modem tick, nothing else, and has been for 3 months, then your action is to explain to the parents, is to educate that it can go away. It's normal for child, adolescents to have modem tick as long as they just happen and they usually go away. Okay, but it can be transitioning uh, a modem disorder. Okay. So this is not Tourette's. What you need to do is reassure the parent, okay, that it usually go away. So your actions should reassure. What are the neurotransmitters? Everyone loves this question, and I see all the time. Is the neurotransmitter involved in interact? Dopamine, serotonin, or epinephrine. What are the neurotransmitters involved in Tourette's? Dopamine, serotonin, or epinephrine. Okay. So in Tourette's, there is a hyperactivity of dopamine can lead to Tourette's. Right? So you can associate this, at least for that purpose, as like schizophrenia too, right? So schizophrenia and Tourette's both, there is a hyperactivity of dopamine. The neurotransmitter involved is dopamine, serotonin, or epinephrine. Now let's stop this right now and group those dopamine, serotonin, and norepinephrine. What are the two other conditions in which dopamine, norepinephrine, and serotonin is involved? Can you remember that? Major depressive disorder is one, right? ADHD is the second. Now we have Tourette's as well. Okay. What are we going to go do? Are we going to give those kids a stimulant? No, no, no. No, no, no. No, no, no. We are going to give them clonidine and guanfacine. Think about this. If I said that the dopamine can increase is responsible for the Tourette's increase, right? Why would we give dopamine stimulants? Just same thing as a schizophrenia. We don't give them stimulants in schizophrenic patient. We don't want to worsen the problem. Here, I said that the dysfunction in dopamine or hyperactivity of the dopamine is the main cause of Tourette's. So we do not want to give them stimulants. In fact, if we give a kid stimulants and they develop tics, our actions should stop. We want to give them a clonidine or guanfacine. All right, acute stress disorder versus PTSD. That's well, I would say the big brother and the little sister. All right, the big brother is the PTSD is older. In order to be a PTSD, it needs to have more than 4 weeks. In order to be acute stress disorder, it needs to have less than 4 weeks. So PTSD, the big brother, acute stress disorder, the little sister here. Okay. So in acute stress disorder, it's less than a month with symptoms. Example, a nurse was attacked with symptoms, was attacked, and symptoms were present for less than 4 weeks. Okay. Then what is it? Is it PTSD? No, no, no. Acute distress disorder. Guys, make sure you know these example, right? It helps you it helps you to kind of memorize when you think about acute stress disorder. Remember, the nurse was attacked. Now she had symptoms for the last 3 weeks. So for the last 2 weeks. Now this is acute stress disorder. In order to be PTSD, she needs to have the criteria met for PTSD, and it needs to be more than 4 weeks. So if a nurse was attacked and had symptoms for less than 4 weeks, this is acute stress disorder. Okay. PTSD, you have an increase in arousal, must be over of the 4 weeks and symptomatic. They have re-experienced symptoms of extreme traumatic event, and they have difficulty oftentimes with the nightmares, right? So what we want to do for those patients oftentimes is ask open-ended question. Don't blame the patient. For example, someone lost her husband in a car accident. Okay. So your job is to listen and understand the patient. You don't want to blame. Let's say the person was driving and there was a car accident. So your job is to listen and understand rather than saying, hey, this is your fault. The therapy for PTSD is EMDR, is the main therapy. You need to know, you need to go back to our modules, know the different phases of EMDR, especially the desensitization, installation, and the body scan. Okay. What is the main treatment options if they have a SSRI versus EMDR or CBT? You are going to pick EMDR. Okay. Now, if the question is asking what is the medication used for nightmare in PTSD, then is prazosin is the medication of choice. Okay. All right. Even though, um, even though not a Seroquel, Zoloft and Praxis are both approved, are both FDA approved for PTSD. Okay, but the mainstay therapy you can be cognitive behavior therapy or EMDR. If the choice between both of them, you pick EMDR. So I wanted just to give you a little bit of the phases here, specifically desensitization, right? This phase reduce or eliminate the intense emotional response associated with the traumatic memories. Techniques such as exposure therapy may be used to help the individual comfort their traumatic experience in a safe and controlled environment. We want to desensitize, right? They want to be more comfortable with the traumatic event. Okay. And then it goes into the installation. During this phase, the focus to instill positive beliefs and coping mechanisms to replace the negative emotions and thoughts resulting from the trauma. This often involves cognitive reconstructing and resiliency building strategies. Okay, if the question asks which of the following phases involved cognitive restructuring and resiliency in building, then you know this is installation. If the question asks which of the phase of a EMDR involved exposure therapy to the traumatic event, then you know this is desensitization. Then finally, the body scan is a phase in which includes mindfulness, somatic uh, techniques that help the individual becomes more aware of their body sensations and learn to release any physical tension or distress treated to related to their PTSD. The body scan is the relaxation method that helps reconnect the mind and the body, aiding the overall healing process. Okay, so this is very important. So finding a way, desensitization, you will re-experience the traumatic event. Oh my God, I had a car accident. So I first see a car, then I first get in a car, the first turning in the key. So each time I'm getting used to it. Okay. Then we have the installation. When I am in a car, I am transitioning those negative thoughts, like I'm gonna die again, with positive ones. Okay. So now I am I am involving cognitive restructuring and becoming resilient building strategy. And finally, I look at myself and I say, hey, I am no longer stressed. It's okay, right? So if I am tense in my shoulders, I can start relaxing and becoming more calm. Okay, ADHD, ADHD. serotonin, dopamine, and norepinephrine. What are the two other conditions that we mentioned for dopamine, serotonin, norepinephrine? Tourette's and ADHD, right? A major depressive disorder. Okay, so the body's functions or body locations or brain locations that are involved usually is involved with ADHD are the basal ganglia, the prefrontal cortex, and the reticular activating system. The three cerebral functions or portion that are involved with ADHD is the basal ganglia, prefrontal cortex, and the reticular activating system. Okay, so if you have the prefrontal cortex that's malfunctioning, you have inattention. If you have the prefrontal cortex malfunctioning, you have inattention, right? Before you prescribe anyone, especially older adults, with a medication for ADHD, you need to assess for cardiac symptoms. For example, asking for AEKG. It's an assessment for cardiac symptoms due to stimulants. Now, amphetamines can be used for child of age 3 and up. Pretty much everything else is 6 and up. You can also use a alpha agonist or alpha 2 adrenergic receptor agonist, which is the non-stimulants. Guanfacine, clonidine, strattera can be used. These are non-stimulants. So the only stimulant that's 3 and up is amphetamines. Okay. So is it methylphenidate? No, no, no. Methylphenidate is 6 and up. Everything else is pretty much 6 and up. But you can use non-stimulants such as guanfacine, clonidine, and strattera. Remember, everything is important, okay? So don't leave any of the lines that are on the slides or the example that we mentioned. ADHD must be present in two settings. ADHD must be present in two settings. It has to be at home and also at school, for example. So the patient may need to be reassured of the benefit of the medication, right? Or the parents. So why? Well, this is actually very real. So when I went to my for my child rotation, I actually met with my professor, and he was my preceptor. He came to my university, and later I went to his hospital, and I had my child rotation there. And I was like, man, I really think my child has ADHD. And he's like, well, here you go. He gave me a Vandenberg assessment, and I completed, and I gave the same assessment, the Vandenberg assessment, to my child's teacher, right? And we're like, oh yeah, I think that's ADHD. And then my mother, I mean, my wife came, and this was virtual, right? Because I was in another state. And then she started crying. And I was like, oh, well, you know, this is serious. I mean, I felt overwhelmed. I was okay with my child having ADHD, but my wife was not. Okay. So this is the example here. The parents may need to be reassured of the benefit of the medication. After all, who wants their little baby to be on a stimulant such as amphetamine at age 3 and up? Okay. Methylphenidate is 6 and up. So if the parent is anxious about the medication, and you are talking to the parents, it's important to provide brief therapy support for the parents. So, what am I talking about? If your action during explaining, hey, your child has ADHD and they needs stimulants, so your action at that point is to focus on the parents, reassure them that the benefit of the medication, the risks and benefits, and provide a brief support therapy to the parents. Cannot be more clear than that. Okay, so please understand those points. So, for example, if the child experiences symptoms after a few hours and the child has been on a stimulant, right? Your priority is to change the medication for a long release or another dose of immediate release. So, what am I talking about here? This is a bit confusing. You started a child on a immediate release, did fine until 2 o'clock. The medication ran out. What happened? The medication got cleared through the body. Now your action is to either do extended release earlier on, followed by a immediate release, or you can just add another immediate release so that by 6 o'clock it kind of warns out and the child is ready to go to bed. Okay, so you need to do a medication adjustment if the child was doing well, followed by the symptoms that happens. The child did well while on the medication worn out, your actions should change the medication to something that's longer or another immediate release because the medication has been clear and the child needs additional medication. So we mentioned that the prefrontal cortex was associated with ADHD. What are the other two body parts? The basal ganglia and the reticular activating system. So if the prefrontal is now working as well, so you'd have problems with inactivity, right? So now one of the parts of the prefrontal is the dorsolateral prefrontal cortex. Here, with the dorsolateral prefrontal cortex, not necessarily ADHD. I just find it a better place for it here since we are talking about the prefrontal cortex. This is not the dorsolateral. One with a dorsolateral prefrontal cortex will have executive function. Well, it makes sense, doesn't it? Cognitive processes such as planning, working memory are disturbed. Problem solved, problem solving is ineffective, and attention tasks with attention. So you need to know your lobes in detail. You need to know your parietal lobe. You need to know your temporal lobe. You need to know your frontal lobe. We cover that in detail. It's not on this presentation, but you need to know because you will be asked questions about the frontal lobe. Frontal lobe, you need to know that the social skills is impaired, language is impaired, memory is impaired, and is your executive functions are impaired, right? On the frontal lobe. Social impairment is very high yield too for the frontal lobe. So, since we are talking about stimulants, what are the signs of stimulant abuse? Does not mean that if they have those signs, they are actually, abusing of stimulants, but are something to be watched, um, to be warned of, or being watching out for. That includes insomnia, tremors, increased blood pressures and heart rate, and heart palpitations. Um, especially those four that you need to memorize. Agitation, anxiety, irritability, and mood swings could also point you to stimulant abuse. OCD, right? So the three conditions, which is dopamine, serotonin, norepinephrine, major depressive disorder, ADHD, and Tourette's. So OCD doesn't have dopamine. So OCD is serotonin and norepinephrine. OCD, serotonin, and norepinephrine. So, what is the OCD, right? So, it's the presence of anxiety provoking obsession, recurrent and persistent thoughts, impulse, or image. So, when we say OCD, right, obsessions, and the compulsion. So the obsessive is the presence of a anxiety provoking obsessions, just the thinking of it. So the recurrent and persistent thoughts, impulse, and image in their head. Now, the compulsion portion is the hand washing. It is the checking the knob? Is it checking the wallet? Whatever that might be the action. So the thought is the obsession. The action of doing it is the behavioral. And then the action here can be tics. So be careful. Be careful. When you hear tics, ask yourself, is there an obsession with it? Okay. So that you don't get confused the tick with the modem tick or vocal tick, right? The track questions can trick you between just because you see tick. It kind of takes you away to a tick disorder or Tourette's disorder, but be careful. That functions to reduce the feeling of anxiety. So here in this case, it is a compulsion. OCDs, they are ego dystonic. OCDs are ego dystonics because they know what they're doing are not realistic, but they just cannot help. So they don't see themselves as as uh self-accepting, right? So they're inconsistent with their self-concept and goals, and accompanied by an increase of anguish and self-discrimination, right? Recrimination. So they're like, oh man, why I keep doing this? I feel so bad. So they know what they're doing, but feel they don't see themselves along with their action. So they're incongruent. So it's ego dystonic. OCD, you need to know that it is a very common at least in tests. I have never seen in real life, but in tests, this is a very common asked questions, and it's in regards to pandas, pediatric autoimmune neuropsychiatric disorders associated with streptococcal infection. If the child went to the hospital and had the symptoms of streptococcal infection, should be considered in all children with sudden onset of OCD symptoms. So here, how it goes: child went to the hospital, was feeling a infection. Which of the following conditions would be most likely the child would develop? Something along those lines, something like that. But the key here is that the child had an infection, a streptococcus infection, a throat infection of some kind, and they develop OCD, right? So options could be major depressive disorder, anxiety, OCD. So you pick OCD, right? Persistent thoughts and tick. I'm highlighting this because that's OCD. Tourette's, you have two modem and one vocal tick. All right, guys. So this is we finished the part two in just under really an hour here. Uh, so this is how we're gonna break down. We are going to make about 5 or 6 little videos, just about 1 hour, and hopefully we catch every single thing. So do not get dismissed by the examples. Do not get dismissed by that not highlighted portion. Every single thing is important. So let's go. Part two. Bye bye.